So it's an immense pleasure, dear ladies and gentlemen, to introduce you David Weinberg, who is an established gastroenterologist from Philadelphia, the US of A. I had the pleasure and privilege to listen to him yesterday when he was giving a motivational talk to high school students at the SEGED meeting, and then spend a little time with him, and I hope he doesn't mind if I reveal a few interesting facts about him in addition to what you really need to know about his career so far. So he's a professor and chairman of the Department of Medicine at Fox Chase Cancer Center in Philadelphia, and I'll tell you about that institution later on. Which means he's also a professor of medicine at Temple University Medical School, because this cancer institute belongs to that university. And while he's a gastroenterologist, he developed an interest in clinical epidemiology and did an MSc on that. He's an advocate for educating primary care and non-oncologist clinicians so that they can provide better care for cancer patients. He comes from a family of physicians. Some of you will realize that when you come from a family of physicians, it's not that easy to make the decision to become a physician and live up to the family expectations and legacy. Ultimately, and luckily for a lot of patients, he became a physician. So he had education, formative years at very prestigious universities such as the Yale, the Cornell University. He even became a member of the Alpha Omega Alpha Society, which I will tell you about later on. He served his residency in Beth Israel Hospital in Boston, and then he did his gastroenterology fellowship in Pennsylvania University. At the time when he was doing his fellowship, he earned the MSc in cancer epidemiology. So I think that it's important to tell you about Alpha Omega Alpha Society, which is an honor society. So you are not part of it just because you are part of a university. It's an honor society because you have to earn the entrance to this society. It was founded to recognize excellence in scholarly achievement and professional conduct among physicians and medical students. There are lots of duties in this society for the greater good, fostering the scientific and philosophical aspects, etc. And I think the motto of this society tells you more than any of the above words: be worthy to serve the suffering. And I wish you all who are going to be clinicians to make that your motto as well. He has had a very interesting time in his life when he was a medical student. He had time out of medical training. So when he was a medical student and 21 years old, he took a year out. Was it a year? Maybe a year. And he joined Dr. Rogers, David Rogers, who was at that time was a 70-year-old man with all the wisdom of an experienced epidemiologist and a specialist in infectious diseases. And they did work together in 1980s New York to deal with the then so-called AIDS epidemics. It was not HIV virus then treated and then cured. It was then AIDS, an incurable disease. And so they did policies on that. And his interest in policy making and public health led him to his role model, who was Rogers. He shared a lot of the principles, what we learned from the Alpha Omega Alpha Society, because Dr. Rogers advocated for the development of programs devoted to primary care for the poor and elderly and greater inclusion of minorities in health professions. So he works in the Fox Chase Cancer Center, which is a large cancer institution seeing 15,000 cancer patients a year, new diagnosis of cancer patients, and providing them diagnosis and treatment. And as I said, it's part of the Temple University. This institution, as he phrased it yesterday, punches well above its weight. It comes from box. So if someone small can hit a big man and make him knock out, that punch is above his weight. So the small institution can be proud of 2 Nobel Prizes and a lot of interesting and important discoveries in recent history of medical research, such as the Philadelphia chromosome, the hepatitis B, and its vaccine. His current research focuses on pancreatic cysts and how they turn into pancreatic cancer. They turn into cancer, 400 pancreatic cysts. You should observe them for 1 year so that one turns into cancer, and he looks at whether the approach by the Fukuoka or the other approach is the best. He's doing a randomized control trial, and we are part of that. He's not only an academic doctor teaching and being a professor at the university, but he's recognized by his colleagues and his patients as the top doctor according to numerous associations and media outlets as well. So you can see the academics. He's the editor-in-chief for Gastroenterology. Gastroenterology is one of the most prestigious journals in GI medicine. It has got a Hirsch index of 484 as of today. So if you want to publish something which you think is important that can change the landscape of GI medicine, you probably should try in gastroenterology. Of course, he has leadership roles with this motivation and commitment in the following societies. And what I learned yesterday when I was speaking to him after his talk in the coffee break, he has, additional to his skills in epidemiology and being a doctor, a personality which you need for leadership roles like this. We consider it a great honor and a true privilege to welcome you to this university, and we look forward to your talk.
Well, thank you for the overly generous introduction. And I am embarrassed, I think, like most people, by seeing a list of things that I've done. So I'm going to change things up a little bit by talking about something that I haven't done much of, but I think it's of interest to all of us. It combines some of my passions of cancer prevention, not only for individuals, but also for populations. It looks at some very interesting science, and it all gets wrapped up into one package that we can talk about in a half an hour or so. So let me start with a very simple question. I will, of course, when any time someone says it's a simple question, that's really a trick. This is a somewhat deceptively simple question. If I could do a blood test, and there's no right answer to this, if I could do a blood test in all of you right now, stick your arm out, we draw your blood, and it would tell you whether you had cancer or not. So you don't need a colonoscopy, you don't have to have a CAT scan, you don't need a mammogram, you have a single blood test that would tell you about cancer anywhere in your body. And for this simple question, don't worry about how much it costs. Just would you do it or not? I need your immediate knee-jerk, quick answer. Would you do it? Stick your hand up. Okay. I don't count that fast, but it's over, certainly well over 60% of people, I think, said yes. Remember that number, because I will ask you the same question at the end of this talk. And honestly, my intention is not to make you say anything different necessarily. My intention is for you to be more educated about what you just very quickly answered a question about. So, moving from left to right are healthy cells, and this is sort of the biology. the cells, quote, become abnormal. They move on to become something that's pre-invasive cancer, meaning it has not left its original organ. It hasn't necessarily even had access to the bloodstream. It hasn't moved yet. Invasive cancer, meaning it's invaded through the basement membrane, for example, spreads throughout the body, and then you die. Somewhere, generally, in the middle, where it says symptom onset, and that's generally in people who have invasive cancer, do they begin to know something's wrong. Sometimes you know before, unfortunately, often you know way after. The idea behind screening, on the left, is to take an asymptomatic population and sort it, and decide who's at high enough risk to deserve some sort of screening test, and who doesn't have a high enough risk to move on to a screening test. Screening can be broken up into preventing disease. So you have a colonoscopy, you find a colon polyps, for those of you who have not seen the light and become gastroenterologists, colon polyps are the stepping stone to colon cancer. One of the interesting pieces of biology about colon cancer is if you remove the colon polyp before the molecular switch, as it were, goes off, and you take it out on December 31st, and on January 1st, bad things are going to happen. If you take it out on December 31st, you're fine. You'll never get colon cancer from that particular polyp. So prevention, never having the disease, is something that you can do with some screening tests. Contrast that with, for example, mammography. Arguably not a great test, but certainly a widely practiced one. And the goal there is not to prevent breast cancer. The goal there is to detect it early, which is generally a laudable goal. So early diagnosis sometimes can happen in people with invasive cancer. The mammogram may find a cancer after the point that it's at least easily amenable to treatment, but the goal of early diagnosis is to diagnose disease when you can do something about it. So in the United States, and I suspect, and I apologize, I'm sure there's similar recommendations in Hungary. In the United States, there are 4 cancers that something called the USPSTF, or United States Preventative Services Task Force, recommends that you screen for. The USPSTF is an evidence-driven organization. It isn't a bunch of experts sitting around a table saying, do this. It's a bunch of experts sitting around a table saying, show us the evidence about whether we should do it or not. And when you look at the evidence, there are only 4 cancers that right now this group thinks you should screen for. Lung, colon, cervix, and breast. Not prostate, not skin, not liver, not lots of things you think there might be screening recommendations for. And in fact, in some cases, for example, pancreas, they recommend against screening. But there are 4 tests, and there are screening tests for those 4 cancers. And the characteristics of how these one test, one cancer approach works is pretty much the same across all 4 cancers. You have a positive screening test, you get a workup for that organ. The mammogram's abnormal, you get a breast exam, you get a biopsy, you get something. The problem is that none of these tests themselves work that well. And the characteristics of the test, the sensitivity, the specificity, the predictive value, is highly variable. In the US, anyway, uptake is suboptimal. It ranges from about 75% for women who should be getting mammograms to about 5% for people who smoke enough to hit the criteria to get a CT for lung cancer screening. And again, in the United States, given our very diverse population and its large size, uptake, who actually does it, is not great. And there are certainly characteristics. Underserved populations do this kind of testing less than more affluent populations for a variety of reasons, which is a totally different talk. So the problem, if you haven't already guessed, with the one test, one cancer approach is that 60% of all the cancers that people get, there aren't any screening tests. There are those 4 screening tests. That's only 4 kinds of cancer. 60% of cancers don't have a screening test. And 70% of cancer deaths don't have a screening test. Further, these tests are not great, like I told you. So if you get them on the regular schedule based upon your age and risk, over time, men, 31% of the time, will have a false positive test. The test says you have something, but when it's evaluated, you don't really. Women, it's much higher, and that's because of the false positive rate for mammography, which is astoundingly high if you get a mammogram every couple of years, starting at the age of I don't know what. Some people say 40, some people say 45, some people say 50. So, why are we talking about multi-cancer detection tests? Well, because clearly there's a problem with the one cancer, one test approach. It excludes most cancer types. You got to have a whole bunch of different kinds of tests, colonoscopies, stool tests, mammograms, et cetera. It's not very efficient, and in the aggregate, it costs a lot of money. It would be very nice if you could have a universal test. Clearly, this is an attractive idea. Why? Well, one test, multiple cancers, same time. You only have to stick your arm out. You don't have to take many days off from work to get a mammogram or a colonoscopy. You just get your blood drawn. That can usually be done in the primary care setting like any other standard laboratory test. And depending on how you do your health economics, it's potentially cost saving. What are we talking about? Well, we're talking about something that goes under the broader rubric of a liquid biopsy. And a liquid biopsy can be from many, many different compartments. So the middle of this slide, where it says liquid biopsy sources at the top, and then cerebrospinal fluid, saliva, et cetera, clearly no one wants to have a spinal tap as their method of cancer screening. So having your blood drawn is a whole hell of a lot easier. Probably giving urine would be even easier than that, but people haven't really figured out how to do that quite yet. What do you look for in the blood test? Well, that is a not all-inclusive list, but you can look for all sorts of things that are measurable in blood, and Dr. Lowe will talk later, perhaps, about some of these things. Okay, screening in general, back to sort of screening 101. What's the ideal screening test? It's sensitive and it's specific. It finds the diseases in the people who has it, and the test is negative in the people who don't have it. It's cheap, easy, can detect disease early enough to make a difference. That doesn't mean you prevent it. That's best. That happens for colon and cervix. Doesn't happen for lung or breast. But detecting it earlier, as we'll talk about at great length in a moment, often but not always is useful. And you don't want the test to have many false positives. Not only does that mean there's a lot of money spent working it up, but if I have no idea who this woman is, but I'm going to point at her anyway, if I told you that you had pancreas cancer based on a test and I was wrong, you would be relieved, but I don't know how hard it would be in you as opposed to you or you to reassure you that this blood test, this fancy new shiny test that your doctor told you should have, I don't know whether you would believe that the test was falsely positive. How about the ideal MCED, or multi-cancer detection test, Well, it can find most cancers, we talked about that. You would want a low false positive rate for the reason I just described. And you would like to, and thank you, Dr. Lowe, again, you'd like to be able to localize where the tumor is with high accuracy. This is a paper published in the New England Journal. I'm sorry, I forgot to put the citation in. It's from probably a year and a half ago. This is not about a blood test for every cancer. This is about a blood test for colon cancer only. And you can see, that's why I put the red box around it, that the sensitivity to find any cancer is okay, 83%. The sensitivity to find stage 1 cancer or stage 2 cancer is a little higher. The ability, by the way, to find polyps stinks. So if you want to have this blood test, you've switched in your mind, whether you're aware of it or not, to saying, I don't care about preventing colon cancer, I care about detecting colon cancer early. Not a bad thing, but if I did another one of those show of hands and said, who would like to prevent cancer versus who would like to just have it detected early, everyone is going to put their hand up for prevention, guaranteed. So it's not clear that this blood test for a single organ cancer makes sense, but it's out there. And before we move on too far, and Dennis probably can tell you far more about this than me, if one of the weaknesses of these blood tests are their inability to amplify to an adequate degree the markers that might be associated with, for example, a colon polyp, right now that is absolutely a weakness of all of these tests. There are all sorts of interesting ideas about how you might do it better. This is meant only, cartoon describes only one thing, but it's a reference from 2024. So this is a very hot topic, and this, at the time, was probably about the hottest idea out there for how you do it. So, what if we're going to do all these things together? So Dave Ahlquist, who wrote this paper a number of years ago, unfortunately died, not surprisingly, of cancer. For those of you who are looking for good career advice, try not to die of what you study. So I study pancreatic cancer. I'm not looking forward to the future if there's any association between those two things. But he did this thought exercise. Now this is a model. This is not data from a study. And he did a couple of things. He assumed that the test, and this never happens by the way, that the test was 100% sensitive to find the disease in question. And in the left panel, you can see at the top that the NNS, the number needed to screen, how many people have to have a test to find one person with the disease. If you are interested only in esophagus cancer, in this exercise, you would need to screen about 1,000 people, and you guys can walk down that curve, stomach, liver, pancreas, colorectal. By the time you get to a test that looks for all GI cancers, in theory, you would need to screen 83 people. And this is not 83 children, this is 83, 60-year-old adults. You would need to screen 83 people, and if you were looking for a cancer in any part of your body, in this calculation, which is probably wrong, and I'll tell you why in a moment, the number is 33. Now, the prevalence of cancer in a 60-year-old population is not 3%. It's probably closer to 1.5% at the most. So the 33 is a smaller number than reality, but the point is, as you begin to aggregate the cancers together, you don't have to test as many people to find one cancer. Now, here is an immutable fact of epidemiology which cannot be overcome. The pretest probability of a disease, prevalence in the population at any one point in time is fixed. It's not under anyone's control. And that number is fairly small. So when the pretest probability of a disease is small, no matter how sensitive and no matter how specific your test, it's still not ultimately going to perform as well as you'd like in the clinical setting of saying, what does a positive or negative test mean for the patient in front of me? And that's what the right panel shows. So remember, they've fixed for this model, sensitivity is 100%. Specificity is 99, 97, 95. If you say that the prevalence of disease in a 60-year-old population is 1.5%, even a test with 99% specificity will have a positive predictive value of 50%. That means half the time it's right and half the time it's wrong. And no matter how good your test, you can't change that. Well, what would happen if we had one of these tests? And as we'll talk about, to some degree, they already exist. This is a paper written by an English group backed by a company that wants to sell these tests to the general population. So take it with a grain of salt. But the point of this slide, I think, is fair. And that's that if you look at all these common cancers listed top to bottom on the left side, breast at the top, colon, etc., in the United States in 2020, the purple squares, for those of you who can't see from the back, which is most of you, purple is the number of cases that would be detected by standard of care testing, mammography, etc. Dark blue are the number of additional cases that would be found if you did the mammogram, and then did the blood test. Purple are the cancers that would be found only by the blood test. It doesn't take great vision to say if you add up all the purple and all the dark blue, that's a whole hell of a lot more than the light gray. Well, that's what we already knew. We already knew that 60 or 70% of cancers don't have a great way to be detected. So clearly, if this blood test worked great, you'd find a lot more cancers than we find now. So, how would you use a test like this hypothetically? Well, at least if this data is any guide, it's a complement, not a replacement for standard of care testing. It was great to screen for cancers without standard of care testing. And the whole idea is if you screen for lots of rare cancers and you add them all together, the number needed to screen to find some cancer is a small, fairly manageable number. Well, as we'll talk about in a few minutes, do you want me to go back to that one? You want me to go back? Okay. The number that actually gets into studies looking at MCEDs or multi-cancer detection tests, that's an interesting thing to talk about. But like most tests of this sort, where the 10, 20, 30-year test you would need to do to prove exactly how well this test worked in the perfect randomized controlled prospective trial, people modeled it before anyone is going to do that study. So if you model it, and you make some assumptions, and remember, these are assumptions, but they're not far-fetched. If there are a little more than 1 million incident, that is new cancer cases in the United States in people 50 to 79, and you had a novel MCED test that was pretty sensitive, 55%, and very specific, then you would find 715 cancers for every 100,000 people screened. However, you would have a false positive rate of 691 people. So as predicted, about half the people with a positive test really had cancer and about half the people don't. And for those of you who are interested in health economics, again, with lots of assumptions, doing this might in fact be cost effective, maybe. It certainly might add some qualities, that is quality adjusted life years, a measure of how to translate extension of life or other important metrics into some sort of comparable scale so you can compare one intervention to another. Okay. Now, maybe you're starting to think, ooh, yeah, 50%, that doesn't sound too bad. I voted yes, I'd have the test. That was the right thing. Well, my job is to make you think. So, cancer screening is based on the premise that early detection is always better than later detection. Intuitively, you think that's true, but it's not. So, if I find prostate cancer in one of the men in this room at the age of 80, the overwhelming possibility is that that man will die with prostate cancer, not of prostate cancer. But if I find a diagnosis of prostate cancer, me or anybody else here, I'd need a biopsy to prove it. That costs money. Biopsies have complications. I may say, because I don't know what the future shows, no matter how much I'm reassured that prostate cancer tends to be rather indolent, I may want to have a prostatectomy. That means that I will have difficulty urinating. That means I might have difficulty having an erection. That means I might have all sorts of problems that I didn't have. And that's okay if I knew it was going to save my life. That's not okay if all I got is the risk, but I didn't get any benefit. I was going to die of something else. So finding cancers early does not necessarily translate into living better or even longer. So, very simplistically, you could argue there are 3 kinds of cancers. Ones that are slowly progressive, where early detection probably helps. Ones that go really fast, so even if you find it early, bad things are going to happen before you can do anything about it. And then indolent cancers, where early detection is of questionable benefit. And no matter how smart the scientists are, nobody yet can distinguish between those 3 kinds of cancers. Why do people care about this? They care about this because there's a ton of money associated with the test that 60% or so of the people in this room, without really understanding what they said yes to, said yes. Okay? So the estimate for multi-cancer detection tests in the US alone, the US market by 2030, not far from now, is about $3 billion. That's chasing enough money that people are going to pay attention. This list, which is probably about 6 months old, are companies that are involved in this field already. You can scan your eye over and you may see the names of some companies you recognize, and you'll see the names of tons of companies you don't. Little startups, not all from Israel. Any number of groups want in on this business. So how well does it work when so these tests exist? How well does it work? Well, here's an early paper from about 5 years ago, and you don't need to see the various cancers, that's what's in each panel, but the idea is pretty much the same all the way across. Each panel's set up the same way. Stage 1 cancers on the left, stage 4 cancers on the right, and for pretty much all cancers, both in the training and in the validation sets, the detection of early stage cancer is not as good as the detection of late stage cancer. Now, for those of you with much clinical experience at this point, I don't need a test to tell me that somebody has stage 4 esophageal cancer. That's worthless. I can stand across the patient's room and know they've got something terribly wrong with them if they have stage 4 pancreatic cancer. I don't need an expensive blood test. What I would want a blood test for is to find disease at the earliest stage. So this earliest data, and there are many new tests and generations of old ones, but this early data, for the most part, is still true. These tests work better to find late-stage disease than early-stage disease. This is a paper published in The Lancet a year ago or so. It's called the Pathfinder study, and it illustrates some very important things. First off, you have to understand who was studied. So they studied about 7,000 people, as you can see. They were all over 50. About half the group, a little more, was at average risk for colon cancer, or for all cancers, and about half the risk, based on family history or something, was not. This is a convenience sample. These are people who agreed to be in a study. This is not just an average screening population. So what important things can you see? Well, the positive predictive value of the test, when people with a positive test were worked up, was about 38%, and that's about what Alquist's graph would have predicted. The negative predictive value is high. That's reassuring, right? If the test is negative, what's the chance you don't have the disease? It's high. The specificity, just like those models, is high. Let's see, what else do you need to see? In this, I tip my cap remarkably to Dr. Lowe. The ability of these tests to do in this next generation what they couldn't do in the first is to say, where is the cancer from? And generally, that's an epigenetic phenomenon that has been now well described. And remarkably, you stick your arm out, the test is positive, and 97% of the time, the right answer, meaning where's the cancer from, starting, is correct. Now, contrast that to the, quote, the way that you used to do it 3 years ago, 4 years ago, where you had to get a PET scan. You just had a positive test. You had no idea where the cancer's from. You got a PET scan. That didn't work so well. So this is a remarkable advance, absolutely remarkable. Okay, I showed you some of the good news. Let me show you some of the bad news about the Pathfinder study if you put your epidemiology hat on. So, of the 121 cancers that were diagnosed in the 12 months patients were followed for this study, only 35 of them were found by the blood test. So all those data about how good it looks, that's how good it looks in the people who had a positive test. Most people with cancer didn't have a positive test. The sensitivity was low, about 30%. It missed many of the cancers. And honestly, of the 35 that it did find, 29 would have been found by standard of care testing. 6 of the 35 new cancers were in fact recurrent disease. So it wasn't a new diagnosis of cancer, it was cancer the patient had had come back. Of the 29 that were brand new, only half were stage 1 or stage 2. And of those 14, only 6 were solid tumors. The others were leukemias and lymphomas. So, and it was not a goal of this study. The goal of the study was not to prove it had a mortality benefit or was cost effective. That's beyond the scope of the study, and that's a very fair thing for the authors to argue. But it's not entirely clear to me, based on this data, how well it really worked if you did it in the big world. So, let's step back for a moment and ask some very philosophical questions. Does cancer screening save lives? I see a couple heads up and down, shaking up and down. Okay, well, I would assume so too. If I find a cancer in you, and you die of something else at the same time, even though I have detected and prevented even a cancer in you, have I saved your life through screening? Probably not. So we're leading to a more general question, which is, what's the right endpoint for a study? What do you actually have to prove in the study that would change your thinking about the test? If the test found tons of cancers and everyone still died of something else at the same time, why are we doing cancer screening at all? Now, I don't have the answer to that. I'm throwing that out there for you to think about. People tend to focus on the benefits of cancer screening, but there are risks of cancer screening, overdiagnosis, things like that. And those tend not to be thought of. But there are some countries, particularly in Europe, where most women, I guess, in this room would assume that mammography is a great idea and I should do it. Switzerland doesn't believe in mammography. They've looked at the data. There's no evidence that it saves a single life. Not a single life. Contrast that with the United States, where every advocacy group keeps saying we should start doing, in utero mammography in women, and the age keeps getting younger and younger, and the false positive rate goes up. The true positive rate does not. Here's a really interesting paper from about a year ago where actually people looked to see in the literature which screening tests actually save lives. Save lives, change all-cause mortality. And the answer is 1. Sigmoidoscopy. All the others, if you're used to looking at plots like this, whenever the arrows cross the midline, it means that there's no benefit. Now, how hard is it to prove in a study, because studies cost money and take time, how hard is it to prove in a study that you can reduce cancer-related mortality, all-cause mortality, the endpoint that you care about? Because the usual argument is it will take too long to get these answers. It will cost too much money. Well, part of the reason is that the actual effect of cancer screening, as the previous slide suggested, is relatively modest, and the likelihood that you are going to die of any individual cancer is actually very small. So look at breast cancer. This is the 10-year risk of death without screening is 4.7 women out of 1,000. In women who get screened, it's reduced in relative terms a lot, but in absolute terms, very little. And even if you work your way all the way down to the bottom, the 10-year risk of dying from some cancer without screening is 35, and with screening is 26. Still an improvement. I'd rather be in the right column than the left column, but it's not as if it goes from 35 to 2. So, if you do the math, and they did it for you, those are the number of people in that sort of the right panel under cancer-specific mortality and all-cause mortality. Those are the number of people that are required to study a single cancer. So to prove all-cause mortality in breast cancer is reduced by some sort of screening test takes nearly 2 million women to be randomized. No one's going to do that study. Colorectal, 6 million, liver, 11 million. But if you get all the way down here to the bottom, another argument for the real study, the long-term, the 10-year study in MCED testing to prove whether it changes all-cause mortality or not, you, quote, only need to enroll 41,000 people. Now, even if that number's not quite right, it's off by 10% or 20%, you're not talking about enrolling 2 million people, you're talking about enrolling 50,000 people, which is a big study. But I've run a study with 50,000 people. I suspect Dennis has also, and maybe people in this room. It's doable. So, let's keep moving so I don't miss too much time here. Let me just make one point. Another endpoint that you could think about is not all-cause mortality or cancer-specific mortality. It goes back to this general idea that finding cancer early must be better than finding cancer late. And in some cancers, that's true, but in many cancers, that isn't. So to make an end point for a study, stage shift, finding cancer earlier, is probably a mistake. However, it gets done, but look, look at these sorts of graphs. So in ovarian cancer, mortality goes down, reduction in mortality, upward sloping curve, as you increasingly reduce late-stage disease. Look at liver and pancreas. You don't have any effect on mortality to speak of, no matter whether you find the cancer early or late. Now, that may change someday when there are better treatments, but it's not changing today, and it's not changing tomorrow. So, here's a study that actually is, in theory, complete in that everyone has been enrolled. So one of the companies interested in this area offered their blood test to the National Health Service in the UK. And they have enrolled, remember, I only want 40,000 people for my perfect study. They enrolled 140,000 people. They chose an endpoint to prove that the frequency of stage 3 and 4 disease was less in the group who got the blood test than in the group who didn't get the blood test. They spent 150 million pounds on this study. They've enrolled everybody, but they're not done yet. And for reasons which I don't know the answer to, maybe somebody in the room does, they were supposed to release the preliminary results about 6 months ago. They've not been released yet. There are all sorts of potential explanations for that. The most cynical, of course, is that the test didn't work. But I'm not jumping to that judgment, and neither should you. So these tests are out there, and in fact, Grail, the company that's backing this test, got approval in the United States to sell this test to anyone who wants it, who's willing to pay for it. So in the US, it costs about $1,000 out of pocket to get this test. Well, there's an awful lot of things we don't know about these tests. And these days, I don't have the best things to say about the National Cancer Institute or the National Institutes of Health or the federal government that I currently live under. But one of the things they're doing right is something called the Vanguard trial, or the Vanguard pilot study, and NCI is the US National Cancer Institute. And they're enrolling 24,000 people, and they are using 2 different companies' MCED tests. The MCEDs from each company are not intended to be all-inclusive. They are not intended to find every cancer. The argument is that maybe you should find an MCED test that works really well for these 6 cancers, and another MCED that works really well for these 6 cancers, and you still get your blood drawn once, but you get 2 different tests. You don't have to have the perfect test for every cancer. And they're interested in a lot of things that don't actually specifically address the things we've talked about so far. So what are they interested in? Well, it's really hard to do clinical trials, and if that blood test is available in the US if you want to pay for it, what's the likelihood you're going to sign up to be in a trial where you may be randomized to not get the blood test? Okay, the test is positive, and there has to be some diagnostic workup. How interested are people going to be in that? How much does it cost? What is the workup? If I ask Dr. Heggie, how do you work up an abnormal mass in the head of the pancreas, I can pretty much guess what he's going to say, but it might not be exactly the way I do it. But if you're going to do a trial, you have to have a protocol. Well, what's the right protocol to work up a mass at the head of the pancreas? You could argue about that all day. How well do the companies do their job? This is never going to be a test offered in your local laboratory like a CBC. So you're going to outsource this, and you're going to send the blood to a company. The company has to turn the results around quickly with high quality. I think they can do that, but you'd want to prove it before you had several million people enrolled. And then, at least in the US, but I suspect in Hungary too, you'd like to make sure that everyone can get this test. Not just the rich people, not just the educated people, not the people who live in Budapest but not outside of Budapest. You'd like to know that everyone can get it. So, I've given you a lot to think about. I am going to ask you again in a moment, where are you voting now? But to summarize, there are lots of unknowns at this point. What's the right study design? How much could the test cost? $1,000 even in the US is way too much money to be cost effective. I don't know what the right number is, but it's less than that. How do you work them up? As I already partially embarrassed my new friend here in the front, what if the test is positive, but we can't find the cancer we think you have? How do people react to that? That's a big problem. How do you use it? How often do you have this test? Do you have it once a year? Once a decade? Once in your lifetime? If so, at what age? And then we talked about equitable dissemination. Okay. Who got a classical education and knows what this is probably a reference to? Okay, you're raising your hand. You made a mistake. I'm raising your hand. So what's the answer? Right. Very good. So most people know that all sorts of terrible things popped out of Pandora's box when it opened. Does anybody remember from your classic mythology training what stayed in the box? Hope. Very good. Whoever's in the back doesn't need to listen to me anymore. Hope stayed in the box. So why do I have this here? I have this here because I don't know the right answer to whether you should have this test or not. I do think we have opened a huge Pandora's box, and if you focus on the standard interpretation of this myth, you only talk about the terrible things that have popped out of the box. But if you really know how the myth is supposed to work, it isn't just terrible things. There's hope. And so the idea that you could do a blood test that might actually do what the 60% of you hoped it would do when you voted yes, I don't think is unattainable. We might not be able to do it now, but we might be able to do it someday in the future. So, again, no right or wrong answer. Who wants the blood test if you could do it on their way out the door now? Okay, a decent number. I think less, but not zero, than before. So I think I've done my job. Remember, though, for those of you who are going to go into healthcare, it took me 45 minutes or so to explain to you a more sophisticated way to look at this. If you're a primary care doctor, you have 5 minutes to talk to your patient, 10 if you're lucky. You're going to spend your 10 minutes talking about this test? You're not. Your patients are going to come in and they're going to say, hey, I read about this thing in the newspaper. So you have to understand it. And you have to know whether or not and in what circumstances you would recommend it to your patients. And if you can't do that, then you're not doing them the service that you should. So back to the lovely introduction given for me. What I think about here is I think that it's a beautiful combination of not only how do you take care of a population, how do you reduce the burden of cancer in a population? This could do it. But to pretend that when you're offering public health interventions that the individual patients aren't the ones who actually get the test and live with the results is foolish. So It's smart, educated people like us who have to understand the issues and be able to interpret it for most of our patients. And hopefully, at least in this regard, you can do a better job than a half an hour ago. So with that, I will stop. And I appreciate your attention.
Thank you so much, Professor Weinberg, for this very interesting lecture on how to look at cancer screening from a different angle. I hope the audience would have some interesting questions as well to discuss. So please, the floor is open for discussion.
So you said that one of the problems with this test is that especially if the patients are older, then like they might die of something else or they might have other comorbidities that are more significant than their cancer. Do you think it would be more beneficial to target this towards younger people?
Well, I think the false positive rate is likely to be much higher in younger people because the pre-test probability that they actually have cancer, if they're 30, is considerably lower than if they're 60. So, no, I don't think it should be done, at least not knowing what we know now. I don't think we should be doing it in younger people. Implicit in your question, though, is something that I think is even more sophisticated, and that's, we've got this test. Maybe this is not a test for everyone. Maybe this is a test that should be used as a second test after some other kind of screening test. Now, that screening test could be a blood test, but there's lots of discussions of things like polygenic risk factors, where you collect clinical data. Do you have a family history of this? Are you a certain age? Do you have certain laboratory tests that are much more easily and less expensively obtained? And only if you have as it were, the wrong combination of responses to that, so that you have a more enriched population you would do this more expensive blood test in, that might make sense. So there are all sorts of efforts, not just in this regard, but in lots of different areas of cancer prevention where you do something called risk-adapted screening. Instead of assuming everybody's at average risk, at face value, most people in this room are probably at average risk for colon cancer. But if you start asking them, you'll find out that some people have a family history in a first-degree relative, but some will have it in a second-degree relative. Some see blood in their stools every once in a while. Some have lost 10 pounds in the last 3 months and there's no explanation. So in theory, they're at average risk, but if you begin to collect a little bit more detailed information, you find out maybe there are strata of risk in that population, and you change your screening approach, even in the average risk population, to try to do the test in people who are most likely to benefit, and by extension, avoid doing the test in the people where the false positive rates are likely to be highest.
Can I ask a follow-up question? So
yes.
For example, in colon cancer, traditionally the population of people who get colon cancer are older in their 50s or 60s, and so that's why they start the colonoscopy screening around 50 or 55, I think. But now there's new studies coming out saying that more and more people are having colon cancer in their 20s or 30s. Do you think it's more beneficial to bring this kind of traditional screening forward to more younger people, or something more like the blood test?
Well, I think I am not the most popular person in the United States because who cares about things like this, because I don't understand why the screening age was lowered in the United States from 50 to 45. I fully, completely, totally acknowledge that around the world, and in Hungary too, the likelihood of getting colon cancer when you're younger is going up. No doubt about it. But it's the difference between relative risk and absolute risk. So if I told you the chance of being under 40 and getting colon cancer in Hungary is 20% higher than it was 10 years ago, anyone under 40 here would go and think, oh, I should get screened. But because this is a very sophisticated audience, some of you are going to say 20% higher than what? And if what was 1 in 100,000, 20% higher is 1.2 in 100,000. So people can relax. But the world doesn't work that way. The world works that way that, you know, there's some story on TV about this, you know, wonderful 22-year-old person in the, you know, in the bloom of health who got colon cancer because their doctor ignored her complaint or his complaint that there was a little bit of blood in their stools. Well, yeah. 10,000 times out of 10,001, that blood in her stools was a hemorrhoid. One time it wasn't. And that's what people focus on. So, do I want young people to get colon cancer? No. But colonoscopies in the United States are a limited quantity. Not everyone can have one. It makes much more sense to get the screening rate up higher in the population at risk if it's a zero-sum game where if I do a colonoscopy in that 45-year-old, I can't do a colonoscopy in that 65-year-old. From a public health perspective, you should be doing colonoscopies in 65-year-olds only. From a personal perspective, if a patient is sitting across from me in the office saying, I have blood in my stools, at some level, even though they're 40 or 45, I'm saying to myself, well, you know, they could have colon cancer, and they get a colonoscopy. So this tension between what happens to individuals and what happens to populations are very different. In a country like yours, but not in a country like mine, if you have a centralized healthcare system that says this is what I'll pay for, and this is what we won't pay for, then those decisions are made by the central government, and those decisions are meant to help the general population, acknowledging that individuals will fall through the cracks. Not many, but some. I'm not sure that the US version is better, because I don't think we do such a great job of keeping people from falling through the cracks. But it's very rare that I say to some patient, you know, your insurance company won't pay for that. So most of the time, people get the test that they want. Whether it's a test they need, that's a different issue.
Thank you.
Thank you.
Thank you so much. Due to the compact schedule, we have to move on to the next lecture. But before that, Professor Weinberg, on behalf of Semmelweis University and the Center for Translational Medicine, it's my honor to award you the Certificate of Contribution at the Seminar Lecture Series. Thank you so much for your time.